Thank you, Corinne, for this kind words and introduction. And indeed, I want to try to explain a little bit about convenience, but also put it in the broader picture of hesitancy and the health system design. So you see the last mile, and that's already a very important point of introduction, that the last mile is not where the vaccine ends into the fridge of a health center, for instance. That's not the finishing point. The photo here you can see is a picture taken from South Africa, Soweto, where the first clinical trials were held some time ago, and you see immediately that this is the last mile. And if this is not working, then let's say the goal of the whole immunization efforts is not realized. So the goal is get this person immunized, and you see immediately a needle, a syringe, a protective clothing, a mask, a person, a nurse, and so on. So that's very important that all of these elements are there to get the system successful. This is my team, and Corinne already introduced transdisciplinarity, and in fact we are a small team, but I can just illustrate that we really need that. The people who are here on the team have degrees in civil engineering, in business engineering, pharmacy, IT, art, architecture, things like that, economy, social science. I think if we collect all that, we can think about this very complex problem from different angles and hopefully get better and more successful solutions. The three pillars of our approach are indeed, as mentioned already, the human-centeredness, the system thinking, and the design thinking. These are three elements we believe through all the projects we have been doing are very important to get, let's say, to a feasible and acceptable solution. Let me start with the human-centeredness. You see the picture there, and I already touched about, let's say, the previous picture, but here you see a very human content at the last mile. You see the baby, the child, that has to be there. For sure, we sometimes forget, does that child easily gets here? Who's deciding for the child? You see the mother there. But in many more cases, you see also not only the mother, the family, the grandparents, the father is engaged, and so on. You see also the nurse, very important, but specifically here, and this comes from our experience in Africa, but I strongly believe that also in our countries this is very important, is the lady you see in blue, that's the community worker. I think that lady visits, let's say, her community, knows what is going on, is coaching mothers and caregivers, and indeed can also be deployed into surveillance, also already pointed out as a very important element. So you need all these people very motivated to get the things done. Then on the top part you see the system approach. I will also show that later more in detail. And that's in fact that what we typically call as a supply chain or a health system is usually part itself of a larger system. And there are a lot of subsystems who have to work together and, let's say, jointly not opposing each other. And sometimes this happens, as I will show you with some examples. The third pillar is the design thinking. That's something we learned from people who design products or houses or whatever. And they are typically user-centered. They think about who will use this house, who will live there. And then it has a couple of steps. We also structured that a little bit through the years. And I will not go into the details, but you see the picture there. It's the back of a skirt of a nurse in Kenya, where the question is, in fact, let me show you how you can save your kid from HIV. So the goal is try to protect your kid from HIV. That's the goal. And for that goal, we will construct a system to do that. And then in 5 steps, we talk about stakeholders, performance indicators, modeling, and then, of course, choices and options also already meant. There's no single unique best solution for everything. We will have options. And finally, we have to decide on these options. And I will also talk about that a little bit later, because this is, of course, an element we face also in the media now. What is the relationship between experts and decision makers / politicians? Okay, this is, hopefully you can read it, both in the room here and at home. This is just a structure of our, let's say, streams of projects. And we do a couple of things about childhood immunization. This is the left one. The second one, as you can see, is about, well, I cannot see it, I'm sorry. It's very, can you see it at home? I don't know. very difficult. Anyway, it's the combination, allow me to explain it, it's the combination of climate change and immunization. You can say, how is this related? Well, it's about, here in this case, yellow fever and rabies. Yellow fever is transported by a vector called Aedes aegypti. This is a small, tiny, let's say, mosquito, and that mosquito survives in places where it didn't survive before. So we have to be ready when this thing develops in terms of vaccination and immunization. We connect that to rabies because a lot of things of the human health have also to do with zoonotics and the health of animals. And of course, rabies, we can vaccinate the dogs. For other animals, it's not that simple, of course, but at least we have to realize that sometimes it's even beyond our human system that we have to look for solutions and designing of the system. Then you see HIV is a specific pillar, of course, where we also have a discussion and some projects on, let's say, prevention, long-acting injectables to replace daily pills, but also a vaccine hopefully will be there in the future. And again, we have to be ready for this immunization system to be performing. Then we can, of course, not escape COVID-19, and we turned into COVID-19 through, in fact, let's say, the emerging infectious diseases. And so WHO has a list of diseases which are not yet fully, let's say, covered by vaccination. There was a top 5 defined and taken over by CEPI. And CEPI contacted us to, let's say, and that was about halfway 2019, so before COVID, they asked us, can you already think about the supply and the convenience for this new to be developed vaccines? We started doing that work, and eventually in March, of course, the question came, can you slow down a bit on these 5 pathogens, and can you turn your attention and most of your efforts to COVID-19, which we are doing today. And then the 5th one, I do not want to, or the 6th one, excuse me, not forget, is in fact a kind of a decision support. We really need decision makers to support them in making their decisions, because it's not something you can calculate and then you have a single number solution. So we really have to work on that from that side. And we also have kicked off a research stream on that. So if I may reconnect it to the things already said about the system thinking, you have the prevention versus the outbreak. I think all of you are specialists, even much more than me in the field, and there's a lot of things to say about prevention and outbreak response. Coming back to the COVID-19, we are mainly now in the outbreak response, but hopefully through time we will go into the preventive mode. And these two are not independent. They live together, and at a certain moment they have to keep each other in balance. Another system thinking idea is prevention versus treatment. We now treat a lot of people for COVID-19 consequences, but of course, prevention will avoid that treatment. And that's one of the very first things we learned in HIV. Now we all try to cure it, try to treat it, but of course in the future we hope that we don't need that treatment anymore. It will of course be a long-standing exercise because it takes decades, of course, to switch from the one system to another and get them into balance. Then the final one, the human behavior. I want to highlight 2 elements of that. One is in the HIV setting, where we learned that because people are not loyal to their treatment, they start, not of course by their purpose, but they start to develop a drug resistance. And if the, let's say, the disease gets resistant to the drugs, then all the offers again have a little chance of getting to their final results. So there we already had that balance between, let's say, so the balance between treatment and prevention, with on top of that a lot of human behavior helping or not helping out. And that's the same thing we see today here in this symposium, that here also human behavior in COVID-19, we see a lot of hesitancy popping up, a lot of things which are not going that well, and I will hopefully show at the end that in fact we really need to do our best, because otherwise we will miss in fact our end line. This is, these are some partners we work with, but it's a diverse selection of companies, universities, and international organizations. So the human-centeredness, I already spoke about that a little bit, and indeed, immunization goal, I don't have to explain that. So the treatment should be, let's say, avoided or at least diminished when prevention pops up. But if we come to the modeling of these systems, I can add a couple of things. So about the vaccine, will these people have access physically, economically, financially, mentally, right? Are they hesitant? The theme of today, and much more will come later this evening. But also about the vaccinator. That person can also be scared. That person may not be skilled for the new things to come. Maybe we need new trained people, very new in the field, and so on. And will the whole thing be safe? Will the person not get other things coming up, like just the safety of the instruments, but also, of course, the disease? For who will we organize this? So there's a big discussion now about the fair and equitable allocation of the volumes of vaccines coming up. In an emergency, you do not have a vaccine for everyone. How will we solve that problem? I will also shed a light on that a little bit later. So it's indeed a discussion about target groups, vulnerable populations. But again, you may all agree that elderly people should be vaccinated first. But what if you do not have enough? How do you solve that problem? And then, of course, by who? Who is deciding this? Which are the experts, the regulatory people, politicians, the businessmen? So all of these are stakeholders in the system, and they have to collaborate to get a final solution workable. This is, of course, I cannot deal with all the details here today, but this is a typical, very aggregate view of the system. So it can be applied for COVID, it can be applied for childhood immunizations or new and emerging diseases, but typically you have R&D efforts, but you see, if we take decisions in the R&D world, it has already an immediate impact on the downstream last mile and a bunch of other things. Let me explain one. They're all now vaccine candidates for COVID-19, which we already know, if it's a good one, and countries and the world chooses for those ones, it has to be stored on -70 degrees, for instance, yes? If this is already decided in the lab, way to speak, yes, then of course the whole system has to be prepared for that. And we know we are not prepared. We have to take action on many points in that. So if it's not only a thing about physical thing, like manufacturing, distribution, storage, it also has a thing about funding. Will it be more or less expensive than, let's say, an ambient or just a fridge to be kept vaccine, you see? So we have to connect all these elements and try to, let's say, assess the impact of all these elements. You can read them, I think, and there are many things we have to deal with. And you see behind all of these elements and system points, you see that different stakeholders with different interests are behind. And that's very important. We can align them. Okay, here also you see at right bottom corner, let's say the outbreak circle, which is the one we want to see smaller and smaller in the future. Then there's a lot to say about design thinking. I will not review all of that because if you need more information about that, I can share that with you. This is a more structured way how you work with stakeholders and their interest and modeling and so on to get to a system design. But what I want to stress here, because it's a very actual theme, is the difference between experts and decision makers, right? What we do in our projects, I'm not telling that this is perfect, but we have good experience with that, is the fact you see there the girl is choosing between a donut and an apple at breakfast, right? If you ask a mother who is concerned or a father about the health of the kid, everybody would probably go for the apple. It's more healthy than a donut. Okay, this is a kind of a general belief. But I'm not so sure in a sense that if that girl has to spend a whole day in school doing sports, in a sports day, maybe at that moment you better give a donut at breakfast, okay? So it all matters what is the context, what is, let's say, the stakeholders' position, but also, of course, you suppose you have the condition that you can only take one of the two and not half a donut and half an apple. So if you invest in a supply system for a vaccine, it's extremely expensive, also in R&D and so on. So you usually only have one moment or one choice or one option. And everybody has to agree, even if that option is imperfect on a particular dimension, everybody realizes and everybody goes for the same chosen solution. I think that's very important. So going to the 5 apples, I'm sorry, my counting is a bit difficult. Yes, 5 apples, right? So you see there 4 green apples and 1 red apple. What is the task, my opinion, of researchers and experts? They decide what are good apples, good-looking apples. All of these 5 come out of the analysis. These are all good options, but they're not equal. You see clearly there's a red and 4 green ones. So it could be that the red one is a very nice one, but also a very expensive one. And the green ones are a little bit less expensive, but they miss a little bit or do a little better on another side, okay? And I think the position of these 5 apples should be offered to the decision maker from, let's say, the expert and scientist, and then somebody else takes within a set of good solutions one solution to go ahead. That's my personal opinion, and as far as we worked it out in the past, it worked. So then coming to the, let's say, convenience part, I see my picture's a bit overruling my title, but this is something we worked out as a simplification, of course, for the neglected tropical diseases I mentioned. We studied here Lassa, Nipah, Rift Valley fever, and a couple of others. And you see clearly you have a basic production of the bug, then it usually has to be transported on site, but is sometimes between continents to, let's say, a form filling and packing facility, and then that goes to a regional store. And then, of course, the distribution in country kicks off, right? That's not unlighted here on the picture. That whole network is a very complex one, a difficult one, because if you have to transport all over the world stuff on minus 70 degrees, for instance, this is not an easy thing to do. So this is a network for only some examples here. So it's a non-COVID. You cannot see that on the title, but this is a non-COVID network, but COVID is very similar. So then you see what does that gives you such a model. When you can see it more or less, it's a bit small, but on the top, this is for chikungunya, then you say, okay, if we have nothing now, and we start having a mass volume production right now, it takes a while before the first batches come out of the system. It takes long, this is a very difficult process, and so on. So you see, but at a certain moment, the first volumes come up, and if the vaccine is to be stored in a strategic stock, so not to be, let's say, deployed in an emergency situation, you can stockpile your vaccines until the outbreaks show up. Okay, that's the normal way of doing. And you see there the stock builds up in green, and then somebody has decided what should be a strategic stock to cover, let's say, the outbreaks you expect. And then the up and down, you see the small outbreaks, and then you cover each time you consume some of your strategic stock, you refill it, of course, because you want to be prepared for the next one. You see there are different regimes, different outbreak patterns. Some of them are seasonal, others have to do with other factors. So you clearly see that there are different outbreak patterns with different stockpile, let's say, modes. But at least it gives you, and that's very important, timely information for what is possible, okay? Then here, this is then turning to the COVID situation. By the way, I have to be clear, this is not, let's say, real-time COVID information. I do want to induce very difficult discussions, but the characteristics are there. So the difference with the previous slide is the fact that immediately as a batch is produced, it will be used for COVID-19 because, you know, we are ready, we are eager to move ahead. So you see that we have a target of producing, yes, and then each time we have a cumulative consumption, and each time a batch is there, it is consumed. So that's why you do not reach your strategic target. We hope, of course, after 2-3 years, that we come into a situation of the previous slide. And by the way, if you would have very strong eyes, which I don't have, you see that if somebody very small in the world tells you that you should start production and you will have a vaccine before the 1st of October, I think you heard that before, you see here mass production for this should have been started late July, which is not the case. Okay, but again, this is not real-time COVID information, but you know what I mean. Then if we embed that now in our COVID situation, I talked already about the vaccine supply is very complex. It's a bioprocess, it's not a chemical process, so it means, in fact, at the end of the process, you cannot immediately see that the product is good. The only way to guarantee a good vaccine is the fact that you did your work very, very well. Nothing went wrong on, let's say, the road to the vaccine, and the smallest thing which is going wrong there, you kick the vaccine out because you have doubts. So the whole quality assurance, quality control, regulatory things are very, very strict and explains quite a bit of the long lead times for vaccines. We try to squeeze that. You know, there's some uncomfortable feeling about the fact that we produce the vaccine for COVID maybe faster, but there is some opportunity there. Before COVID, we studied the rotavirus vaccine, because also there was a higher need than the, let's say, the supply, and there was a question, can we do it faster? There are some opportunities to do it faster, so I think most suppliers try to build on those opportunities there. But I think on quality, there will be no compromise. And then, of course, for COVID, we start from scratch. There was even not very much known. It was known, but not very much. So what we typically call here in building such a system is the unavailability of all repository knowledge. We have to, by week and by month, build up that knowledge. So it means that our models continuously adapt and change. Data change, the structure of the model change, decisions are made on different levels. So we have to be very dynamic and adaptive, which is another characteristic of a transdisciplinary approach. Okay. Then validation is not easy, it's time dependent. I already explained that to you. The living model, I also talked about that, right? The ecosystem is also part of the game. Then maybe a final word on the allocation. So you have seen this volume. The network can produce volumes. These volumes are to be served to a demand, but that's of course, the volumes will be split and the demands will be converged in particular country demands, for instance. And this is, as you can see it there in, let's say, descriptive words, it is the health outcomes we want to maximize subject to diverse constraints. And to be sure, this is not easy to define in a sense. Okay. Where does it come from? There are some principles, of course. This is something you probably have already seen yourself. These are the guidelines of WHO, which they published. So how will we start with distribution? And if you allow me, so there's the goal of the system, which is already multi-objective, if you can read it nicely. There's some time aspect in there. There is some, let's say, priority aspect in there. There is also a buffer, which already hints to the strategic stock for stockpiling, right? So for emergencies, even in the COVID, let's say, rollout situation. And we have already some numbers where we can say, okay, let's try to figure that out. Then this will be built into a model. I will not go into the details, but the allocation model will be one of the very important models for the next months, as you can imagine, especially of these time-dependent shortages with time-dependent needs. Okay, and then there's another difficult thing. Because we have a network, that network gives some throughput, so that network we have established now can produce so many vaccines of these technologies and these characteristics. The countries will try to absorb that. There will, of course, be shortages in the beginning, right? So we will learn from that we would need more from the network, so we will play in the network, and so we have a kind of a circle, and this is, of course, something very difficult. Because where do you start? Do you start in the needs, or do you start in the supply? Because it's something which is really not independent. That's a very important characteristic of a system approach, and we can model that, fortunately. So you see here also a way of, let's say, on a very aggregate way to model this. I like this one very much because here you see clearly what is the prevention, the planned immunization, and what is the emergency immunization with, of course, maybe campaigns. There are very different forms where you can do that. And of course, these are not independent. The better you do in prevention, the less outbreaks, of course. And if there's an outbreak, also your planned immunization system hopefully can cope with additional efforts to this outbreak response. And then this is one to close. So already explained in the very beginning, and my circle is almost round. We have the nurse, we have the syringe or the vaccine, we have the patient, or the person. It's not usually a patient, it's usually, hopefully, a healthy person. And I want to share, oh, this is a bit problematic because the slide has shifts. Okay, let me just visualize it. Okay, it's doable. So you see there the base case. Suppose we have a 95 availability of the vaccine, 5% stock outs. In several countries, this is not an exception. The workforce is available for 95%. Okay, and then you have a 95% population. This is the hesitancy. So the people are afraid of the vaccine. So 95% of the people show up to be vaccinated. If these are independent element, which is not, but suppose they're independent for ease of calculation, you see there we have an 86% of success. That all these things are there, and that, let's say, 86% of the goal of the system is realized. Suppose now the first one, the vaccine drops to 80% due to production problems, transportation problems, whatever, doesn't matter much what. So you see immediately what will be the consequence. Your final result drops to 72%. If you, for instance, take everything back on the good track, but you say the workforce is sick, is infected by itself, and goes to a 75% availability, you drop to 68%, right? Even if you, again, have a healthy, let's say, vaccination staff, but the people are very scared, and you go to 70% of, let's say, people who are getting to the vaccination, and to state it easy, 30% of, let's say, hesitant people, you go to 63%. And I definitely don't dare to put all three things. If they all happen at the same time, you can calculate yourself. So we will end up with, let's say here, a 50% of immunization, which is definitely not enough, as Corinne explained, to get the things done, despite all the efforts we do now. So I think this should be an eye-opener for those who definitely don't see what an effort on all these different aspects means at the end of the day. Okay, so this is then my final slide. This is the COVAX facility, also known to you, I think. And if you look at that carefully, if you analyze that, it also contains the elements of this system thinking. It's the small circles you see with the arrows, excuse me. These are in fact signals that this is an iterative feedback type of element in the system. So we will definitely not be done after choosing our first options. We have to rethink, revisit, adapt until I think more or less the things get balanced. Voilà, this was my talk. I hope I stayed within the time limits.